Hello everyone in Cardio Minds channel and welcome to the fifth video in the ESC Guidelines for Atrial Fibrillation 2024, and today we are discussing the second letter in the care pathway for AF, which is A, standing for avoid stroke and thromboembolism. Of course, the first priority that we all think of when we are dealing with an atrial fibrillation patient that we need to avoid any thromboembolic complications. The most famous is a stroke, but there are other thromboembolic complications like acute lower limb ischemia or mesenteric vascular occlusion. So today we are discussing how to prevent these complications, and our agenda today that we are speaking about the thromboembolic risk and how to assess, the choice for oral anticoagulants, thromboembolism despite anticoagulation which may occur in some patients, left atrial appendage closure and when do we send the patient for this procedure, and assessment of bleeding risk. Let's start with the thromboembolic risk. Let's elaborate some facts first. Of course, AF is a major risk factor for thromboembolism irrespective of the temporal type, whether it is paroxysmal, persistent or permanent. Theoretically, the higher the burden of atrial fibrillation, of course, the higher the risk, but this doesn't mean that, for example, paroxysmal AF is at low risk for thromboembolism. No, we should deal with all of these types as a major risk factor for thromboembolism. Also, if it is left untreated without oral anticoagulation, the risk of ischemic stroke is 5-fold higher. Of course, the risk depends on the risk factors in each patient, but in general, the risk is extremely elevated if the patient is not anticoagulated. And 1 in every 5 strokes we see in our clinical practice is associated with atrial fibrillation. That's why all of the neurologists search for atrial fibrillation in any stroke patient, and the default approach is to provide oral anticoagulation to all eligible patients except those who are at low risk for thromboembolism, which have usually CHA2DS2-VASc score of 0, and the effectiveness of the oral anticoagulation to prevent ischemic stroke is well established in the clinical literature and by evidence from clinical trials, and all of us know that antiplatelet drugs, even the dual antiplatelet, are not recommended, are not alternative for stroke prevention in AF. The default approach is oral anticoagulation. What about reminding ourselves with the component of the CHA2DS2-VASc score? Letter C stands for chronic heart failure, which means symptoms and signs of heart failure irrespective of LV ejection fraction. So it may include HFrEF or HFpEF or heart failure with mildly reduced ejection fraction, and it includes as well presence of asymptomatic LV ejection fraction less than or equal 40%. In this case, the patient takes 1 point. Hypertension, it means that the resting blood pressure is more than 140/90 on at least 2 occasions, or the patient is receiving antihypertensive treatment at the time being. And of course, we know from the previous videos that the optimal blood pressure target associated with the lowest risk for major cardiovascular event is systolic from 120 to less than 130 and diastolic from 70 to less than 80 mm mercury. We elaborated this fact in the last video of the comorbidities, and also this is the same target in the 2024 ESC Guidelines for hypertension. In this case, the patient takes 1 point. If the patient is 75 years or above, age of course is an independent determinant of risk of ischemic stroke, and in this case the patient takes 2 points. Presence of diabetes, whatever type 1 or type 2, is defined by currently accepted criteria, or the patient is receiving treatment with glucose lowering therapy, the patient takes 1 point. Presence of previous thromboembolism, either prior stroke, TIA or arterial thromboembolism, this patient is at highly elevated risk for recurrence, and so the patient takes 2 points. Presence of any vascular disease like coronary artery disease, including prior MI, angina, chronic coronary syndrome, history of revascularization like CABG or PCI, or presence of significant coronary artery disease on angiography or cardiac imaging, or the patient has peripheral vascular disease like intermittent claudication, previous revascularization by surgery or percutaneous intervention, any intervention on the aorta or presence of complex plaques on imaging like features of mobility, ulceration, pedunculation, or plaque thickness more than or equal 4 mm. In any case or any feature of them is present, the patient takes 1 point. And if the age is from 65 to 74 years old, in this case the patient takes 1 point. As we can see here, female sex is no longer included in the CHA2DS2-VASc score because in most of the clinical literature it is considered a risk modifier rather than a risk factor per se. And of course we remember the confusion that sometimes it was mentioned in the previous guidelines for atrial fibrillation that if the patient is a male and CHA2DS2-VASc score is 0, or the patient is a female and her score is 1, just because she is a female, she will be dealt with regarding oral anticoagulation the same like the male with CHA2DS2-VASc score 0. That's why it doesn't make sense in order to put 1 point for female sex at the time being. That's why it is no longer included in the CHA2DS2-VASc score. So whatever the patient is male or female, in this case the score would be 0 if he has no or she has no other risk factors for thromboembolism. And in general, most of the available risk scores have a threshold of 0.6 to 1% risk of thromboembolic events per year for clinical AF patient in order to start oral anticoagulation. This means that if the patient's CHA2DS2-VASc score is 1, this means that the risk of stroke in this patient may reach up to 1% per year, and this justify starting oral anticoagulation. Besides these risk factors included in the CHA2DS2-VASc scores, there are other factors or markers that may modify an individual's risk for stroke and thromboembolism, and they should be considered in our assessment for the thromboembolic risk, even if we are not starting oral anticoagulation based on their presence, but we should put them in our mind that this patient is slightly at elevated risk for thromboembolism, like presence of cancer, like chronic kidney disease, which increase both thromboembolic and bleeding risk. Some ethnicities like Black, Hispanic, and Asian patients are at elevated risk. Biomarkers like troponin and BNP, if they are elevated. Atrial enlargement, of course, increase the risk for atrial thrombosis and so increase the risk for thromboembolism. Hyperlipidemia, which is commonly associated with hypertension and diabetes, that's why in this case you need to make sure that the patient is hypertensive or diabetic or not, because in this case the CHA2DS2-VASc score will be higher. Smoking, of course, increases the risk of thromboembolism. And don't forget that obesity is considered a risk factor for stroke, and most of the obese patients may have hypertension or diabetes or vascular disease. That's why presence of these factors should get you more attentive to the risk of thromboembolism in this patient. So what are the recommendations regarding thromboembolic risk? First of all, oral anticoagulation is recommended as a class 1 in any patient with clinical AF at elevated thromboembolic risk to prevent ischemic stroke and thromboembolism. And if the CHA2DS2-VASc score is 2 or more, in this case it is recommended as an indicator of elevated thromboembolic risk, and so this patient should start oral anticoagulation as a class 1 recommendation. Also, oral anticoagulation is recommended in any AF patient with hypertrophic cardiomyopathy or cardiac amyloidosis regardless CHA2DS2-VASc score, because in this case the patient is at elevated risk for thromboembolism, so we do not calculate CHA2DS2-VASc score, we directly start oral anticoagulation. And we should do some individualized reassessment of thromboembolic risk for each patient at periodic intervals. For example, a patient who has now CHA2DS2-VASc score of 0, next year he may develop hypertension or diabetes, and in this case the score is 1. When a patient reaches the age of 65, he adds 1 point to his score. That's why it is a dynamic score and it needs to be reassessed at periodic interval. For example, every year we need to recalculate CHA2DS2-VASc score to assess the indication for anticoagulation. And if the CHA2DS2-VASc score is just 1, in this case it is a class 2A that this patient should start oral anticoagulation. That's why any patient with a score 1 or more will start oral anticoagulation, but of course if the score is 2 or more the risk is higher, and so it is a class 1 recommendation. But still, with a score of 1, it is a recommendation as class 2A. And one of the biggest dilemma regarding the patient who have pacemakers and it detected subclinical atrial fibrillation or atrial high rate episode, if those patients are at elevated thromboembolic risk, we can start for them direct oral anticoagulant or drug as a class 2B, but we should exclude those at high risk of bleeding, because in this case, if the risk of thromboembolism outweighs the risk of bleeding, it is justifiable to start, but the evidence is not very strong for them. So far, the duration and burden of subclinical AF that could indicate potential benefit from the oral anticoagulation remains uncertain, but it is not wrong for you to start oral anticoagulation, especially DUAC, for a patient with subclinical or atrial high rate episode in their cardiac pacemaker if they have elevated thromboembolic risk without high risk of bleeding. And the big no regarding thromboembolism is that antiplatelet are not an alternative to anticoagulation in any AF patient to prevent stroke and thromboembolism, and you should not use the temporal pattern of clinical AF like paroxysmal, persistent or permanent, because all of them have an elevated thromboembolic risk. That's why we just check the CHA2DS2-VASc score without paying attention to the temporal type of clinical AF to determine the indication for oral anticoagulation. Now we decided that our patient is indicated for oral anticoagulation. What type of anticoagulation we are starting with? We all know that the vitamin K antagonist or VKA, the most famous one is a Warfarin, but it includes also other types like fimprocomone and asencomarole. It increases the risk of intracranial hemorrhage and other major hemorrhage, and this is the most critical limitation for acceptance of VKA as oral anticoagulant, beside of course the need of frequent monitoring of INR to make sure that we reach the target because of the unpredictable effect of warfarin between different patients. That's why drugs were a good choice, because they demonstrated at least non-inferior efficacy as compared with warfarin for the prevention of thromboembolism, but there was an added privilege that they showed 50% reduction in the percentage of intracranial hemorrhage. And for patients undergoing cardioversion, we usually have a protocol that we can adopt 3 weeks or in some hospitals 4 weeks of adequate anticoagulation without missing any dose. 3 underpowered trials showed non-significantly lower rates of cardiovascular events with drugs compared with warfarin. That's why we can adopt drugs for 3 weeks at least before a patient scheduled for cardioversion, and if the patient didn't miss any dose, we can go directly for cardioversion without a transesophageal echo. And specific patient subgroups showed consistent benefits with drugs versus VKA. For example, in heart failure patients, major thromboembolic events were much lower in drug-treated patients versus warfarin in subgroup analysis of the landmark randomized control trials. You can check the reference for this trial in the description below the video. And this justifies the choice of drugs in preference to VKA in the clinical practice. We have 4 famous drugs that we all know. The most famous one is Apixaban, which is taken in a dose of 5 mg twice per day. When should we reduce the dose to 2.5 mg twice per day? If we have 2 out of 3 risk factors, like age more than or equal 80 years old, body weight less than or equal 60 kg, serum creatinine more than or equal 133 millimole, which is equivalent to 1.5 mg per deciliter. If we have 2 out of these 3 factors, we can reduce the dose. And don't forget to advise the patient to take this medication twice per day at the same time every day. This enhances the efficacy of Apixaban. Regarding Dabigatran, it's taken in a dose of 150 mg twice per day. Sometimes we need to reduce the dose to 110, not the half, just 110 twice per day. If any of these factors apply, like age more than or equal 80 years, or receiving concomitant verapamil, because verapamil may increase the anticoagulant effect of Dabigatran. And sometimes we may consider dose reduction if the age is between 75 to 80, or the patient is having moderate renal impairment with creatinine clearance from 30 to 50 because we know that below 30, Dabigatran is contraindicated. Patients with gastritis, esophagitis, or gastroesophageal reflux, we may consider reducing Dabigatran dose, or other patient at increased risk of bleeding. That's why Dabigatran is not one of the favorite choice for oral anticoagulation in AF patient due to some restrictions in its use. Regarding Edoxaban, it is taken in a dose of 60 mg once per day. And when should we reduce the dose to 30? If any of these factors apply: moderate or severe renal impairment with creatinine clearance between 15 to 50, body weight less than or equal 60 kg, or concomitant use of cyclosporin or dronidarone or erythromycin or ketoconazole, because they also enhance the anticoagulant effect of Edoxaban. That's why we try to avoid these medications if the patient is taking Edoxaban. And usually if the creatinine clearance is more than 90, which we sometimes call it supernormal kidney function, we prefer to avoid Edoxaban because its renal elimination may be more rapid and this may jeopardize its anticoagulant effects. And another famous drug is the rivaroxaban, taken in a dose of 20 mg once per day, and it should be taken once per day after meals because this increases the absorption and bioavailability of the medication. When should we reduce the dose to 15 mg if the creatinine clearance between 15 to less than 50 milliliter per minute? We can observe here that creatinine clearance below 15 is not mentioned here regarding the dose adjustment. For example, in European countries, reduced dose of rivaroxaban, Apixaban, and Edoxaban are approved in all patients with severe CKD with creatinine clearance between 15 to less than 30, although limited numbers of patients were included in the major randomized controlled trials against VKA. But below 15, we usually avoid these drugs except for Apixaban, which is allowed in some clinical trials to be used in creatinine clearance less than 15, but in these guidelines below 15 we usually prefer the choice for vitamin K antagonist. And of course, as the Dabigatran is more dependent on renal elimination, it is contraindicated if the creatinine clearance below 30. Some small trials have been performed in patients with end-stage renal disease on hemodialysis with no difference between Apixaban 2.5 mg twice per day and VKA regarding efficacy or safety. That's why we can use Apixaban according to some evidence in hemodialysis patients at 2.5 mg twice per day. Other papers spoke about using a higher dose of 5 mg, but so far the standard dose is 2.5 mg, and one trial showed that rivaroxaban 10 mg once per day led to significant lower rate of cardiovascular events and major bleeding compared with VKA. That's why the only anticoagulants allowed for use in creatinine clearance below 15 are Warfarin, of course, and in some clinical literature, Apixaban 2.5 mg twice per day is allowed. And which situations should we avoid drugs in? Of course, we all know in mechanical heart valves, drugs have no proven efficacy. For example, one trial was comparing the Dabigatran with VKA in patients with mechanical heart valve, and it was terminated prematurely due to excessive thromboembolic and major bleeding events in those taking the Dabigatran. Another trial comparing Apixaban with vitamin K antagonist after implantation of mechanical aortic valve, and also it was stopped prematurely due to excess thromboembolic event in the Apixaban group. What about bioprosthetic valve? So far the restriction on drug does not apply to bioprosthetic valves, including even mitral valve bioprosthesis and after TAVI, as drugs showed non-inferiority for clinical events compared with VKAs in these situations. Some clinicians, of course, will still prefer in the first 3 months after bioprosthetic mitral valve replacement for rheumatic, moderate or severe mitral stenosis, they would prefer Warfarin, and after 3 months they may switch to drug, or other clinician may prefer Warfarin, but in general we can use drugs for bioprosthetic valves. The second situation is moderate to severe mitral stenosis, as most of the trials comparing drugs versus VKA excluded patients with moderate to severe mitral stenosis, which is mostly rheumatic in etiology. And a clinical trial including 4,531 patients with rheumatic heart disease, and 82% of them had mitral valve area less than 2, VKA led to a lower rate of composite cardiovascular events and death in comparison to rivaroxaban, without a higher rate of bleeding, supporting the restriction of drug in patients with moderate to severe mitral stenosis. What about other valvular disease like mitral regurgitation or aortic stenosis? So far, they can be prescribed drug, and that's why we need to avoid the term of valvular AF, which is obsolete, because some may misunderstand that valvular AF applies to any valvular disease patient having atrial fibrillation, and that's why they will just prescribe VKA and avoid the use of drugs in those patients. No, we only avoid drug in patients with moderate to severe mitral stenosis, which is mostly rheumatic, but in other valvular disease with atrial fibrillation, we still can use drugs. This is a famous diagram showing all of the interactions possible with each type of oral anticoagulant. Of course, I cannot explain it, but we need to keep it as a reference for ourselves. And let's remind ourselves that there is something in common between all of the oral anticoagulants, that we need to limit the consumption of grapefruit juice, which may enhance the anticoagulant effect of the medication, and St. John's wort, which is a type of herbs that is used usually in treatment of anxiety and depression. We need to avoid their use because they enhance the anticoagulant effect. And regarding warfarin, we need to advise the patient to reduce or try to avoid alcohol as much as he can, because alcohol enhances the anticoagulant effect, and also cranberry juice. But with other medication, we need to check whether this medication needs to be avoided with this anticoagulant, or we need to reduce the dose of the anticoagulant. So what are the recommendations regarding the choice for anticoagulants? Of course, drugs are preferred to VKA as a class 1 to prevent ischemic stroke and thromboembolism, except in patients with mechanical heart valve or moderate to severe mitral stenosis. In those patients, you need to use VKA. Target INR is between 2 and 3 in all of the patients in order to reduce the risk of stroke and ensure safety and efficacy without increasing the risk of bleeding. Switching to drug is recommended as a class 1 for any eligible patient who fail to maintain adequate time in therapeutic range. We call it TTR, standing for time in therapeutic range. If it is less than 70%, in this case, this patient should switch to drug in order to prevent thromboembolism and reduce the risk of intracranial hemorrhage. Keeping the TTR above 70 should be a class 2A recommendation to ensure safety and efficacy, because the patient may be taking warfarin, but if he is not achieving target INR or TTR above 70, in this case it is futile, and we need to regularly check INR at appropriate frequency with the patient involved in the management of his dose and INR with adequate education and counseling. And so VKA are currently the only treatment option in AF patients with mechanical heart valves, moderate to severe mitral stenosis, and also in patients with antiphospholipid syndrome. Still, VKA have much stronger evidence than drug, and limited exception to use drugs in patients with antiphospholipid syndrome with weak evidence. So far, VKA have the strongest evidence in antiphospholipid syndrome. And there is an important issue regarding patients more than or equal 75 years. In those patients, it is a class 2B to keep VKA rather than switching to drug, especially if these patients are taking polypharmacy, because in this case the switching to drug may increase bleeding risk. One of the famous trial called Frail AF trial, which was prematurely stopped due to futility, because switching from VKA to drug in those patients led to a higher primary outcome rate of major or clinically relevant non-major bleeding events compared with just continuing VKA with achieving target INR. That's why in those patients, if they are controlled on warfarin, leave them on warfarin and do not switch them to drugs. And the big no regarding anticoagulants, that a reduced dose of drug is not recommended unless the patients meet the drug-specific criteria to prevent underdosing and also avoid thromboembolic events. Don't tell yourself, this patient may have elevated bleeding risk, so I will reduce the dose. No, in this case, you are not giving him adequate protection against risk of ischemic stroke. That's why DUAC therapy should be instituted according to the standard full dose tested in the phase 3 randomized controlled trials and approved by the regulators, and this was issued in this guidelines. And another big no regarding combining antiplatelet with oral anticoagulant for stroke prevention, that adding antiplatelet treatment to oral anticoagulant is a class 3 because in this case it will increase the risk of bleeding events, and there is no benefit that this reduces the risk of stroke or risk of mortality. That's why this should not be a practice. It is prohibited because in this patient you are exposing the patient to higher risk without added benefit. And needless to say that dual antiplatelet therapy including aspirin and clopidogrel still less effective than oral anticoagulation in prevention of stroke and thromboembolism and should not be used as an alternative. In the ACTIVE-W trial, DAPT with aspirin and clopidogrel was less effective than warfarin for the prevention of stroke and thromboembolic complications with similar rates of major bleeding. So just keep on oral anticoagulation in the full dose. Now let's move to one of the weird situations in which the patient develops thromboembolism despite anticoagulation. Is this a common situation? Unfortunately, 1/3 of patients with AF presenting with ischemic stroke are already taking oral anticoagulation, and there are heterogeneous etiology for this situation. For example, it may be due to non-AF related stroke mechanisms, so the patient is having AF, but it is not just simply embolic stroke. It may be due to large artery or small vessel disease. Sometimes a patient was non-adherent or non-compliant to the anticoagulant. Low dose of anticoagulant if the doctor prescribed a lower dose than usual, or the patient from himself reduced the dose because he was concerned about some bleeding, for example. This may result in a stroke, and sometimes it may occur despite sufficient anticoagulation. Lab measurements of INR if the patient is taking VKA or checking DUAC serum level may contribute to revealing the amenable cause of this stroke. So in the guidelines, class 2A is that you should have a thorough diagnostic workup in any patient who develop thromboembolic complication despite taking oral anticoagulants in order to prevent recurrent events, including assessment of non-cardioembolic cause, assessment of vascular risk factor, the dose that the patient was taking, and whether the patient was adherent to this anticoagulant or not. And the big no, we have a lot of big no's today in our video, that you may think that I should add antiplatelet treatment to this anticoagulation because this patient developed stroke on anticoagulation. So far, there is no benefit from this practice. It may be theoretically right, but practically this patient didn't have any added benefit in the clinical trials, and they are exposed to higher bleeding risk. And also switching from one DUAC to another, for example, the patient developed stroke on rivaroxaban, so shall we switch him to Apixaban? Or the patient was taking Apixaban, shall we switch him to Warfarin? So far, there is no clear indication that this practice is beneficial in those patients to prevent recurrent strokes. Just keep on the same anticoagulant and try to check one of the causes that may justify or may explain the occurrence of stroke despite anticoagulation. Now a big question that we all ask ourselves: should we schedule those patients to left atrial appendage closure or not? So far in the guidelines, the only indication for percutaneous left atrial appendage closure as a class 2B, still a weak evidence, that those patients who are having contraindication for long-term anticoagulant treatment to prevent ischemic stroke and thromboembolism. So occurrence of stroke despite anticoagulation is not a justifiable indication for appendage closure, but if the patient is having an absolute contraindication, in this case we can put percutaneous left atrial device in order to reduce the risk of stroke. Despite the paradox that the need for post-procedural antithrombotic treatment expose the patient to a bleeding risk, still this practice may be beneficial in order to avoid long-term anticoagulant treatment, because the antithrombotic regimen after the appendage closure include 45 days of VKA plus aspirin after implantation. In some hospitals, drugs can be used at full or reduced dose as an alternative to warfarin after Watchman device, for example. Then 6 months of dual antiplatelet therapy if there is no major device leak, then lifelong ongoing aspirin. So in this patient, you try to avoid lifelong oral anticoagulation, so this antithrombotic regimen may expose the patient to a higher bleeding risk, but in this case the patient can avoid long-term oral anticoagulation. Another approach is to have a standalone endoscopic surgical closure of the left atrial appendage in those patients who have contraindication for anticoagulant therapy. Here, while the percutaneous left atrial appendage closure or catheter group showed higher acute success rate, it was still associated with a higher risk of hemorrhage in the peri-operative periods. But in this group with surgical endoscopic closure, there is no need for post-procedural anticoagulation after epicardial closure, and that's why this is a potential advantage for the standalone epicardial over percutaneous closure. But still, it is a class 2B recommendation. The only class 1 recommendation for left atrial appendage closure is for surgical closure as an adjunct to oral anticoagulation in those already undergoing cardiac surgery, for example mitral valve replacement. So in this case, if the patient is having surgery, it is a class 1 to close the appendage, or during endoscopic or hybrid AF ablation to prevent stroke and thromboembolism as a class 2A. Otherwise, just a standalone appendage closure, either percutaneous or endoscopic, is just class 2B, not for patient with occurrence of stroke despite anticoagulation, but for patient with contraindication to oral anticoagulation. The last item that we are going to speak about today is the bleeding risk. How can we assess the bleeding risk and what does it indicate? Clinicians should consider the balance between thromboembolic risk and bleeding risk, putting in their minds that the factors for both of them are dynamic, and that's why we need dynamic reassessment of these risks at periodic interval and sometimes overlapping, and it needs to be reassessed at each review depending on the patient, because it may become higher with regular clinical reviews. Bleeding risk factors are not a reason to withhold oral anticoagulation except in very limited indications, because the risk of stroke without anticoagulation outweighs the risk of major bleeding. The only problem is in those with non-modifiable risk factors, who should be reviewed more often and, where appropriate, with a multidisciplinary team approach. But we do not withhold oral anticoagulation just because of elevated bleeding risk. Which risk score should we use? So far, this task force does not recommend a specific bleeding risk score. Why? Due to uncertainty in its accuracy, and also potential adverse implications that if you calculate the risk score and it showed elevated bleeding risk, you may withhold oral anticoagulation for those at elevated thromboembolic risk. Despite Hasbled score is still the most famous score to be used, but this task force does not recommend using of any bleeding risk score to avoid the misunderstanding that this patient should avoid oral anticoagulation. Of course, I know that many of you ask themselves, what are the absolute contraindications to oral anticoagulation which justify going for left atrial appendage closure? These contraindications usually apply to drug therapy, and they represent primary intracranial tumors or intracerebral hemorrhage related to cerebral amyloid angiopathy. But what about intracranial hemorrhage in general? So far, drugs can be safely initiated or reinitiated after acute bleeding has stopped, as long as the source has been fully investigated and treated. Otherwise, if the patient is having intracerebral hemorrhage due to cerebral amyloid angiopathy or associated with primary intracranial tumor, in this case it is an absolute contraindication that justify going for appendage closure, but intracranial hemorrhage in general is not an absolute contraindication to restarting oral anticoagulation. What about proton pump inhibitors? We know that co-prescription of a PPI with oral anticoagulation is common in clinical practice, especially in those at high risk of GI bleeding. However, limited evidence has been shown that those patients benefit from PPI, and in a large trial in those receiving low-dose oral anticoagulation and/or aspirin for stable cardiovascular disease, pantoprazole had no significant impact on reducing upper GI bleeding compared with placebo. That's why the use of PPI should be individualized according to the risk of GI bleeding in this patient. For example, patient who already had history of GI bleeding, or he had an upper GI endoscopy showing gastric ulcer or duodenal ulcer, or the patient has chronic liver disease with increased risk of esophageal varices. In this case, it is justifiable to co-prescribe PPI. So the recommendations for the bleeding risk is that we need to assess and manage modifiable bleeding risk factors, and that is the concept of assessing bleeding risk, to check the modifiable factors that can be controlled in order to reduce the bleeding risk in those eligible for oral anticoagulation. And the big no, do not use bleeding risk score to decide on starting or withdrawing oral anticoagulation. No, just check the modifiable factors in order to control them, but avoid underuse of anticoagulation just because of the bleeding risk. This diagram illustrates to us how to manage the high bleeding risk and how to control the risk factors. So we need to take a comprehensive history to determine all of the risk factors for increased bleeding risk at oral anticoagulation initiation or follow-up. And of course, class 3, do not use bleeding risk score to decide on starting or withdrawing oral anticoagulation. Manage all of the modifiable bleeding risk factors with shared decision making. Give us some example. Hypertension, we need to optimize blood pressure, lowering treatment in order to reach the targets, because uncontrolled hypertension increases the risk of bleeding, and try to avoid non-steroidal anti-inflammatory drugs due to the risk of GI bleeding. Regarding antiplatelets, we know that sometimes we need to combine antiplatelets with anticoagulant in the first week or sometimes in the first months after PCI or after MI, and up to 1 year the patient may take dual antiplatelet therapy including an anticoagulant with clopidogrel. But beyond 12 months, please do not add any antiplatelet. So if this patient had PCI by 1 or more stents, after 12 months you only keep him on anticoagulation? Yes, I only keep anticoagulation beyond 12 months with no need for antiplatelets. And of course, we know that drugs are preferred to VKA in order to reduce bleeding risk, and this is a class 1 recommendation. Advise the patient to reduce alcohol intake to less than 3 standard drinks per week to reduce the anticoagulant effect of the medication, and better to avoid it. And other factors should be considered like drug interaction, reducing corticosteroid use, offering PPI to those at elevated GI bleeding risk, and restricting hazardous hobbies or occupation like some sports or some hobbies that may increase the risk of contusions and bleeding. Keep the target INR in those taking VKA between 2 and 3 with TTR more than 70, and if the patient is eligible or fail to maintain adequate TTR above 70% on VKA, switch to DUAC, and minimize the duration of heparin bridging therapy. Then move to addressing all of the potentially modifiable bleeding risk factor with shared decision making with the patient like anemia, thrombocytopenia, renal impairment, risk of falls, diabetes, and congestive heart failure. Make sure that you manage heart failure and achieve a volemic state. This helps to reduce the bleeding risk, and effective glycemic control for diabetic patient should be achieved. Then there is a problem with some non-modifiable bleeding risk factors like age, like previous major bleeding, like severe renal impairment or severe hepatic impairment or cirrhosis, malignancy, some genetic factors, previous stroke, cognitive impairment or dementia, and intracerebral pathology. In this patient, you just need to review the patient more regularly and work with multidisciplinary team to monitor the risk factor. And if there is clear contraindication for oral anticoagulation, class 2B to go for left atrial appendage closure, for example Watchman device or other type of device, in order to avoid long-term oral anticoagulation. Then you need to reassess the patient at the next interaction in order to assess the bleeding risk, because as we know, it is a dynamic risk. Then this diagram represents how to deal with a patient on oral anticoagulation who present with active bleeding. First of all, you need to compress the bleeding site mechanically if accessible. Then assess the hemodynamic status to assess the need, for example, for blood transfusion. Assess the basic coagulation parameters, blood count, in order to assess the degree of blood loss and kidney function. Then determine the dose and time of last oral anticoagulation and all of the co-medication. The management is different whether this patient is taking VKA or DWAC. If the patient is taking VKA and develop minor bleeding, of course, in all of the bleeding situations, regardless anticoagulation, we need to interrupt anticoagulation and perform diagnostic and treatment intervention to control the bleeding, then try to delay or omit VKA till the INR get less than 2. If the patient is having non-life-threatening major bleeding, also interrupting anticoagulation, but then multidisciplinary team approach to decide on fluid replacement, blood transfusion, and we may consider the need for antidote like vitamin K antagonist, fresh frozen plasma, and the most specific antidote for VKA is prothrombin complex concentrate. But if the patient develops life-threatening or bleeding into critical site, besides the interruption and the diagnostic and treatment interventions, we need to consider prothrombin complex concentrate as a priority here beside fluid replacement and blood transfusion. If we do not have prothrombin complex concentrate, we can use fresh frozen plasma, and some patients may need replacement of the platelets if indicated. If the patient is taking DWACs, nearly the same approach with little changes. In minor bleeding after interrupting anticoagulation and the diagnostic and treatment intervention, just skip DWAC dose for 1 or 2 doses or more depending on recovery. If the patient is having non-life-threatening major bleeding, the same approach beside fluid replacement, blood transfusion, and we may consider oral charcoal or gastric lavage if the DWAC was taken within 2 to 4 hours, and then consider the need for prothrombin complex concentrate, which may be beneficial even in those taking DWACs. But if the patient had life-threatening or bleeding into a critical site, in this case, we need to consider specific antidote. For example, idarucizumab for those taking Dabigatran, or andexanet alpha for those taking Apixaban or Edoxaban. And if these antidotes are not available, in this case, we can use prothrombin complex concentrate, and we may consider monitoring of the DWAC level. So the mode of action is different according to the severity of bleeding and the type of anticoagulation. Then after the bleeding episode, we need to discuss the benefits and risk of reinstating oral anticoagulation in a shared decision-making approach and multidisciplinary team. Try to check whether there is any contraindications that we mentioned before to restarting oral anticoagulation. Otherwise, we need to restart the anticoagulation once the source of bleeding has been addressed and managed, and assess the risk of repeat bleeding. Try to intensify the EF efforts in order to control the modifiable bleeding risk factor. Decide when to start oral anticoagulation and what is the adequate dose for this patient, and institute close and ongoing monitoring because of the risk of recurrent bleeding events. And finally, what are the recommendations for bleeding in anticoagulated patients? Of course, class 1, to interrupt anticoagulation and perform the adequate diagnostic and treatment interventions in any AF patient with active bleeding. Prothrombin complex concentrate should be used as a class 2A in those developing life-threatening bleeding or bleeding into critical site to reverse the anticoagulant effect, and specific antidotes should be considered in patients on DWAC who develop life-threatening bleeding. If they are not available, in this case we can use prothrombin complex concentrate even with DWACs. If no one of them is available, in this case we may use fresh frozen plasma, although it is less effective than the first 2 antidotes. So this diagram summarizes most of the recommendations that we discussed today regarding how to avoid stroke and thromboembolism in AF patients. And so our take-home message today is that assessing the thromboembolic risk in any AF patient is a critical priority to decide on the need for oral anticoagulation, and high bleeding risk is not an indication to withhold oral anticoagulation, but to control modifiable risk factors. Please do not withhold oral anticoagulation just because of high bleeding risk, because the risk of stroke is higher than the risk of bleeding. Thank you very much for watching this video, and you can find the reference for most of the trials in the description below the video, and wait next week for another video in the guidelines of atrial fibrillation.